Good morning, and thank you for attending the keynote address, which will be given by Dr. Earl Benjamin. We want to thank you overall for attending the 2020 Behavioral Health Symposium. We're happy to host this event as a virtual conference because we care about your health and safety, but we also understand how important it is to provide relevant and robust continuing education to Louisiana healthcare professionals. For quality purposes, all participants will be muted during the presentation. If you would like to submit a question to the speaker, please use the Q&A feature in the virtual platform. A little bit about continuing education hours. This session is accredited for 1 hour for the following: social workers, that's for an ethics credit; peer support specialists; psychologists; nursing, this is for contact hours; AMA PRA Category 1 credits; and licensed professional counselors. Full participation is required to receive credit and will be monitored throughout the session. You will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Additional information is available in the digital event booklet. Regarding financial disclosures, Dr. Benjamin has no financial disclosure. None of the members of the symposium's planning committee or any session moderators have any financial disclosures. A little bit about our keynote speaker. Our keynote address this morning is entitled Behavioral Health Disparities, Eliminating and Improving. The keynote speaker is Dr. Earl Benjamin Robinson, who is the Deputy Director of the Office of Community Partnerships and Health Equity in the Louisiana Department of Health. He led the development of Louisiana's first health equity plan and is thus leading efforts in LDH to operationalize health equity protocols and practices agency-wide. Dr. Benjamin Robinson is a public health practitioner with over 19 years of experience and is an adjunct faculty member in Xavier University's Public Health Science program. Since 2015, he's been distinguished by the American Psychological Association as a health equity ambassador and is a practitioner scholar member of the Health Disparities, Education, Awareness, Research, and Training, also known as HDIRT, Health Equity Scholars, and is the co-founder of the Bach Group, a community behavioral health consultation firm. Lastly, Dr. Benjamin Robinson is an alumnus of Loyola University, the University of Louisiana at Monroe, completed postgraduate work at the University of Mississippi Medical Center and Johns Hopkins University, and is a Doctor of Health Science graduate from Nova Southeastern University, Dr. Kiran C. Patel College of Health Sciences. Thank you, and without further ado, we welcome Dr. Benjamin Robinson.
Thank you, Dr. Jefferson. So thank you guys for having me today to share a little bit of information with you regarding health equity, particularly as it relates to behavioral health. This is an unusual setup, but during this pandemic, I'm glad to see that we're moving forward with providing education to helpers that are focused on behavioral health issues. I see myself as a helper, and I use that language because it reminds me of something someone that I look up to who is no longer with us, Mr. Rogers, said a long time ago. He was describing a situation where he was talking with his mother and he was a child, and there was some commotion going on. And he was like concerned, afraid, upset, and he looked to his mother. And she said, always look for the helpers. And so when I think about behavioral health, when I think about public health, when I think about those individuals who are providing care to individuals, I see us as helpers. And so today's conversation is about helping us to be better practitioners inside the behavioral health spectrum. And so thank you and for having me, and I look forward to this dialogue that we're going to be having. Well, I'm going to be sharing some information, and we're going to have some questions at the end. And so this conversation is centered around, the title of the conversation is Behavioral Health Disparities, Eliminating and Improving. And so I'm going to be having this conversation via the work that and the processes and the products that we developed inside the Louisiana Department of Health in my office, Office of Community Partnerships and Health Equity, to help operationalize health equity best practices. I believe what we have put together inside our health equity plan is something that is applicable to all organizations, particularly those helper organizations, those organizations that are trying to support people in being the best individuals that they can be, support people in achieving the best health outcomes that they can achieve. And mental health is indeed one of those areas that's vital to us creating better communities. And so one thing that I before I get started, I want to say that there are three things that this conversation will highlight. One of them is that we will get an identification of what health disparities are, behavior health disparities are. You will have the opportunity to discuss what are the best practices that can be implemented inside your respective areas. And you will also learn about some of the social determinants of behavioral health. And that's very, very important because, you know, in this day and time, we're starting to have more conversations about determinants, in particular, social determinants. But today I want us to focus on social determinants of mental health, because social determinants of mental health should become a part of how you are informing the work that you do to better meet the needs of the people that you're serving. Oh yeah, I'm sorry. Next slide. So as she stated earlier, I have no financial disclosures. And just want to briefly talk about, since this conversation is centered in behavioral health, I want to talk about why one of the catalysts for us being here. We have disparities in behavioral health. We know that people who live in rural settings, they have higher rates of suicide and depression. We know that there's a disparity between men and women. Women have more risk, prevalence, presentation, treatment issues when it comes to disparities when it comes to mental health or behavioral health issues. I think an important thing to note regarding this is that women are twice as likely as men to experience anxiety and post-traumatic stress. Research is also indicating that Native Americans, Alaskan Native populations have disproportionately higher rates of mental health problems than the general population. Rates of mental health in the African American community are similar to the general population. However, there are disparities when it comes to them having access to services and culturally competent services. LGBTQ individuals are more than twice as likely than heterosexual counterparts, men and women, to have mental health disorders in their lifetime. And lastly, several cultural and structural barriers prevent Asian American Pacific Islanders from accessing mental health services. So there are a plethora of disparities that we can choose from inside the environments that we work. And as a helper, it's important that we understand the nuances of the population that we're serving so that we can better meet their needs. We can't create just cookie cutter approaches to meet the needs of populations that we're serving. We have to understand what are the different health outcomes, what are the different experiences that these individuals are happening, and use that information to inform the work that we do. At this point, I probably would have asked, are there any questions? But there's no one but a few people in the room, so I'll keep going. So barriers to care. And I'm gonna go through this briefly. So these are the barriers that affect access to treatment as it relates to behavioral health. And many of you already know most of these barriers. It is a lack of insurance, underinsured, mental illness stigma, often greater among minority populations, a lack of diversity among mental health care providers. Going back to the second bullet, I can recall growing up as an African American, we would have individuals in my family who certain things were happening, and we would say things like, well, they had a nervous breakdown, or they went to the club one day and someone slipped something in their drink and they haven't been the same since. And so for me, I know the realness of those cultural stigmas and misinformation that exists. So it's a really big thing in all communities, but in particular in minority communities. The third one, lack of diversity among mental health practitioners. I recently had a conversation with a provider, a nurse practitioner in the state, who was really concerned about making certain that during this time of COVID, that certain populations, low income, minority populations, are getting the services, culturally competent services that they need. There's a lack of cultural competent providers that can be a barrier. Barriers to, language barriers, distrust in the healthcare system, and inadequate support for mental health services in safety net settings. And so these are some of the barriers that exist as it relates to the disparities that are happening. So we are all we're not having the same experiences. We're not coming from the same environment. We don't necessarily have the same resources, but we can't continue to create these cookie cutter approaches. We must understand that the people that we're serving, they're having different experiences. And so as helpers, it's our responsibility to identify what these nuances are and let that inform what it is that we do as helpers. So I want to start with some definitions. Health equity is the attainment of the highest level of health for all people. Health equity means efforts to ensure that all people have full and equal access to the opportunities that enable them to lead healthy lives. Health disparities are differences in health outcomes among groups of people. And health inequity are the differences in health that are avoidable, unfair, and unjust. Health inequities are affected by social, economic, and environmental conditions. This is, for me, as a person who has been working in public health a long time, this is where the rubber meets the road. We must understand that health equity are not just health disparities, but they are health disparities that are avoidable, unfair, and unjust. And so there are some things that we might possibly be doing inside our services, inside our programming, that may be barriers to people. And so as helpers, one of the first things that we can do to help eliminate and prevent disparities is assessing that and understanding what part we might be playing in contributing to some of the disparities that are experienced by the people that we're serving. So again, health inequities, the differences in health that are avoidable, unfair, and unjust. Health inequities are affected by social, economic, and environmental conditions. And just like the individuals you're serving live inside those environments, your organization, your services also operate inside those environments. And so they are affected by those social, economic, and environmental conditions. And we need to be aware of that. Few more, the last three definitions: health inequity, health inequalities, the distribution of health disparities between different populations, health determinants between different population groups. And so determinants we're talking about are social determinants. Today we're going to be calling them social determinants of behavioral health, but really at the core we're talking about social determinants of health. These are the conditions in which people are born, grow, work, live, and play. It is a wider set of forces and systems shaping the conditions of the daily life. As a helper, and I'm going to be reiterating the importance of letting social determinants inform the work that you do. As a helper, as a person developing programming, as a person trying to improve someone's self-efficacy, as a person trying to support people in making behavior changes, you have to be thinking about what the social determinants are that are contributing to this, and use that information to inform your work. You can't just be saying, oh, here's a pamphlet, oh, here's some counseling. You need to be thinking about what are those factors that this individual keeps bumping into inside the environment that they keep going back to. And that has to be used to inform what you do. And so at our core today, the last definition that I want you to remember is the behavioral health equity. It is the right to access quality behavioral health care for all populations, regardless of individuals' race, ethnicity, gender, socioeconomic status, sexual orientation, or geographic location. And that's a lot to do. But there are certain things as helpers we can do inside our work, and that is start to assess how people are experiencing their environments. Use social determinants of health to inform your work, and that will make you a better practitioner. That will make you a better helper if you have a better understanding of what it is that someone who is impoverished is going through inside their community. Someone that might be transgendered, what they're going through inside their community. Someone who lives in a rural setting, what they may be going through inside their community. What a woman goes through inside her lived experiences. And so we need to be thinking individualistically as best we can, because sometimes we can't do it all. But when we are seeing that women are having different experiences as it relates to behavioral health issues, when we're seeing that rural individuals are having different experiences, when we're seeing African Americans having different experiences, when we're seeing LGBTQ individuals having different experiences, and as a result of all of those experiences, they're having disparities in their health outcomes, we have to have some real discussions about how those experiences need to inform the work that we do. So I'll leave you with this again. Behavioral health equity is the right to access quality behavioral health care for all populations, regardless of the individual's race, ethnicity, gender, socioeconomic status, sexual orientation, or geographical location. It is not about my values, attitudes, and beliefs inside the care and service. It is about meeting the needs of the people. And so when developing health equity approach, at this point, we're gonna talk a little bit about what we did inside my office in developing our health equity plan, because I think what we did will help to inform the work that you guys do inside your plans. And so one of the first things that I did was I identified what were the programs that were being offered related to health equity. What were the measurements that helped us to understand how effective we were doing as it related to health equity, and what were the policies, the big policies, whether it is laws or whether it was policies inside the office, what were those policies that were pushing us to ensure that we were considering people's social, economic, and environmental factors? What were those policies or measurements that were ensuring that we were taking into consideration what trans individuals were experiencing, and how were we measuring that? What were those programs that we were providing to those most vulnerable or underserved populations to better meet those needs? And so when you think about health equity, you can't do just one of these. You have to have, if you're gonna be effective, and if you're gonna be sustained in creating something that moves and supports health equity, you need to make certain that you have program, that you have measurement, and you have policies that are in place. And so this is what we did inside LDH. I first assessed what were the programs, what were the measurements related to those specific programs, and what were those policies related to health equity. And so in doing so, what I then did was decide that, what I want to do is to help build people's professionalism, help build their understanding of what were health equity best practices that need to be used inside their environment to help better meet the needs of the people. And my theory was, if I was able to build individuals' LDH professionalism or professional development around public health, we could thus improve services. And as a result of improving those services, we would improve the health and health outcomes of the people that we serve. And so my plans were rooted in how I was planning to operationalize health equity inside LDH, was rooted in building, focused on building professional development. And as a result of building that professional development, we're hoping that we will improve services and improve the health outcomes of the people that we serve. Now, as it relates to improving services, there are also protocols and processes that we are putting in place along with the training to help ensure that improvement of services is taking place. So again, I guess the theme behind our phase one, and it was a phase one health equity plan. We're in the process of developing phase two. The theme of it was LDH professionalism, improving services, and improve health and health outcomes of the people that we serve. And so we had some priorities that we started with. We had maternal health issues that were prioritized. We had cancer, breast and cervical, colorectal cancer priorities that were outlined, HIV, Hep C, and health and behavioral health. Priorities were outlined as well. And so what we found is when we looked at all of those health issues, we found that they had a commonality. We found that they shared social determinants. They shared barriers to health. And so in analyzing that and seeing that, we came up with a framework that was for our health equity plan that dealt with professional behavior, improving professional behavior inside the organization. That was one area that we wanted to focus on. We wanted to focus on changing our supporting organizational culture, and we wanted to make changes inside organizational systems. So based on what we prioritized, we saw that there were some barriers that each of these health disparities shared. There were some commonalities as it relates to social determinants. Based on those findings, we noticed that there were these 3 areas that we could definitely do some work inside our health equity plan. Again, those areas were focused on professional behavior and actions. It focused on organizational culture, and it focused on organizational systems. There were things that we were going to be activating in each of these spheres. And so after doing that assessment, we came up with this clarion call document. If you want to see this document in its full form, or an actual visualization of it, if you go to LDH, Office of Community Partnerships and Health Equity, if you go to Google and put in LDH, Office of Community Partnerships and Health Equity, this page will come up, and that one of the links on the page is this document, and it's called our Barriers to Health Fact Sheet. And on this fact sheet, we outline 3 things. We outline that sometimes organizations, institutions themselves can become barriers. 3, that was number 1. 2, we outlined that when you look at health priorities, many of the health priorities that we're working on, they share barriers. They share social determinants. And based on the social determinants that they're sharing, there are things that we can do inside our organization to help counter some of these health disparities related to maternal health issues, related to cancer, related to HIV, and related to Hep C and behavioral health issues. There are things that as a public health entity, as helpers, there are tactics that we can implement or lean into as we develop and implement our interventions inside our organization. And so just to look at, and again, you can find this document on my webpage, LDH, Office of Community Partnerships and Health Equity, and it's called the Barriers to Health Fact Sheet. And if you turn to the last page of the fact sheet, and again, this fact sheet, it's our clarion call for our health equity plan. One says that sometimes organizations and institutions can be barriers in how they operate. 2, the health priorities, many of the health issues that we're dealing with inside our state, they share social determinants of health. They share barriers. 3, there are things that we can do to counter the disparities that are happening as it relates to health issues. And so some of the things that we outline, and this isn't necessarily saying, it is indeed not saying that an institution has to put up monies to do what these tactics are on the second page. But an institution needs to be aware of these tactics so that they can identify community assets, they can identify the people inside the community, community-based organizations, partners inside the community that can be integrated and woven into their work. And so some of the things that are outlined inside our clarion call document is partnering with stakeholders, doing place-based interventions, improving program collaboration and service integration, like sustainable housing efforts, food security efforts, job employment efforts, Job Corps, GED, adult learning courses. It's not saying that we are responsible for doing this, but we can indeed identify those resources inside the community and lean into those resources and incorporate those resources into our work. Thirdly, develop policy approaches that change the context from prevention. And what I mean by this is, inside LDH, there are many different programs that are going on, but they sometimes stay in their silos. And there are missed opportunities where we can be incorporating what's happening in this silo across the board so that more people have access to it, so that we just aren't creating programs that just sit here and no one gets to utilize. Increase staff understanding of and their capacity to address barriers to disease and prevention. Offering trainings like undoing racism, undoing transphobia, poverty trainings, ACEs trainings, building people's capacity to understand what are some things that could be, that I am doing, that could be affecting the quality of work that I'm providing. What are those things that are affecting how I develop programming? And just one of the last ones is creating safe spaces, working with partners, using those partners to help you create or lean into safe spaces that may be needed to meet the needs of certain vulnerable populations. And again, this was a document that came out of us understanding that we have identified these priorities, and these priorities are helping us to build professional development, change organizational culture, and also change organizational systems. Putting these action steps in place inside these areas led us to develop this first document, our Clarion Call, which again, just to reiterate, it articulated, one, that we can be a barrier sometime. Two, the disparities that we are experiencing, the health issues that are happening, they share determinants, they share barriers, they share social determinants. Three, you can use what you know about those social determinants, and outlined on this document are 10 to 11 tactics that can be incorporated into your work, into your program development to better understand and meet the needs of people. So as I stated earlier, the three things that came out of our assessment process led us to understand that we wanted to improve activate around professional behavior actions. We wanted to change organizational culture, and we wanted to change organizational systems, put processes in place at every point of this structure to help support us in improving LDH professionalism, improving services, and improve health outcomes of the people that we serve. And so when you look at our plan, again, it is on LDH's website. If you go to LDH, Office of Community Partnerships and Health Equity, when you look inside our plan is outlined as strategies and action steps. And it reads very, very simple. a health equity action team. The significance of this team is to develop, to look at data on a monthly basis and make decisions about how to utilize that data to inform or change programming services. Oftentimes in programs, we like to think that people look at data ongoingly, but this doesn't happen. Oftentimes people look at data only annually or every 3 to 5 years, but inside our health equity plan, we are looking at data on a monthly basis. That's why there's their requirement to have the repository there so that the data can be placed there so that when people are not even having meetings, they can go and look at the data. And so this is, when we look at the health equity plan, 95% of this work is geared towards the health equity plan. The development of the health equity action teams, their responsibility is to look at data, make recommendations, see if we're doing best practices, and make recommendations to leadership inside the organization. The other one is community engagement framework. It's a framework that outlines activities that are centered around building relationships with community and the people that you serve. Again, community-based participatory research and the class standards, the national standards for cultural and linguistic appropriate services, and then the inclusion and diversity statements. These are all components that are outlined inside our health equity plan, and each of the offices inside LDH has a responsibility to work on and achieve specific activities around each of these action steps. So again, behavioral health equity. It is about advancing health equity, advancing health equity in behavioral health involves ensuring that everyone has a fair and just opportunity to be as healthy as possible. Oftentimes when we think about behavioral health equity, for a long time, this idea of integrating healthcare is the only way to eliminate behavioral health disparities. It is not. Let me repeat that. Integrating healthcare into behavioral health is not the only way to eliminate behavioral health disparities. There are many studies that are out there that speak to, it is effective overall for the general population, but when we start to look at minority populations, when we start to look at issues of different languages, we're not seeing that we're getting the bang for our buck. So I'm not saying that integrated healthcare is not good. It is good, but I'm saying that it is not the fix-all to behavioral health equity. And integrated healthcare is not the only way to eliminate behavioral health disparities. And so, some of the social determinants that are affecting, the social determinants of behavioral health that are affecting the health outcomes of some of the people that we're serving. Employment, and again, you guys already know this, employment, housing sustainability, insurance status, proximity to service, culturally responsive care, interpersonal family and community dynamics, social support, work and school conditions. It's imperative, and I've stated this at the beginning, I'm going to say this throughout, that we understand what these social determinants are. And we use these social determinants to inform how we operate inside the community. I'm not saying that an organization has to become responsible for housing, but an organization can know all of the housing resources inside community and incorporate that information, those services into the work that they do. I'm not saying that it's the responsibility of an organization to develop employment opportunities, but an organization can know all of the employment resources that exist inside the community and use that information to inform their services. Since these are the determinants of behavioral health, these are the things that affect a person's ability to complete programming. They affect a person's ability to flourish inside that treatment plan. And so if you are not incorporating, or if this information is not informing how you work with them, you're doing yourself a disservice. So it's imperative that we continue to, as helpers, look at what those social determinants of behavioral health are and use that information to inform the work that we do. Again, this is how we operationalize health equity inside LDH. We developed health equity action teams. These are teams that look at data on a monthly basis and have conversations about what they are finding. They have conversations about the vulnerable populations that they're providing services to, and engaging in ongoing conversations about what can we do better. They're looking at needs assessment. Again, this is about doing something on a monthly basis to assess where the issues are. Two, this goes with the Health Equity Action Team, a place where the data is kept so that we don't lose time looking at data. 3, community engagement framework. 4, we are operating from community-based participatory research when we're studying the individuals that we're providing care to, making certain that they are part of every level of that study process. We are incorporating culturally and linguistically appropriate service standards where we can and where it is applicable. And we're also, across the board, we've developed an inclusion and diversity statement and clause that help to, one, tell the employees or the people that work at LDH that we value diversity and inclusion. And then as it relates to the clause, in the coming year, we're going to be adding a clause to all contracts and MOUs where all individuals that we have contracts and MOUs with will have to sign it. It doesn't say that they have to do anything. It's just that they're acknowledging that LDH values health equity and diversity and inclusion. And so it's sending a message to the individuals that work inside our institution, and it's also sending a message to the individuals that we're working with that exist outside our institution that we prioritize this diversity and inclusion, and this is a part of how we are building and sustaining health equity. And one of the places that we are working to build and sustain health equity inside LDH. And so how can what I've talked about that's in LDH Health Equity Plan help to inform what it is that we can do as practitioners in mental health, behavioral health settings? Okay, in behavioral health settings. I'm not going to read through what the major action steps because I've done it enough, but as it relates to LDH health action steps, I think these are 3 things that need to be taking place that can help to reduce disparities and improve health equity in behavioral health practices. The constant utilize data to identify and monitor and respond to behavioral health disparities. Just don't look at data when something happens. Be looking at data consistently. We know that we have disparities when it comes to women and behavioral health issues. We know that we have disparities when we come to African Americans, Asian Americans, Native Americans. We know that we have disparities when it comes to rural versus urban patients. We know that we have disparities when we come to LGBT populations. We understand that. So we need to be looking at the data around those vulnerable populations consistently. And looking at that data helps us to stay prepared and helps our programs to respond accordingly to the disparities that we see happening. So utilizing data to identify and monitor and respond to health behavioral disparities. 2, expand the behavioral health workforce capacity to improve outreach, engagement, and quality of vulnerable and underserved populations. That's why this is where understanding what the social determinants of behavioral health are, utilizing that information to inform how you do your outreach, how you engage with community, will be an asset to what you're doing as a helper in the behavioral health field. And then 3, promote policy initiatives that strengthen the impact of your programs in advancing behavioral health equity. At the beginning, I said that there were 3 areas that are needed to effectively manage or build health equity programming. That one is programming, one is programming, the other is measurements, and the other is policies. You can't do all this without having some real policies in place to help ensure and give what it is that you want to do at reducing disparities, give it some teeth. And so there needs to be policies in place that push you to do these things ongoingly. And so like we've done at LDH, we've developed health equity action teams that look at data on a consistent basis, on a monthly basis, and make recommendations to their leadership. We are requiring that all offices engage in community engagement activities annually. They have to meet so many. We are making certain that if any research gets done, it is done from the perspective of community-based participatory research. We are using class to help inform how we are providing care to individuals, and we're creating diversity and inclusion statements and clauses to help ensure and signify to employees and people outside LDH that we value diversity and inclusion. And so these are the small policies that we've put in place to help ensure that health equity, health disparities will be decreased, and health equity will support our efforts in improving health equity inside LDH. And so I'm gonna go to, so I outlined the 3 in the previous, which is to the left, but I wanna go to what your organization can do to help operationalize this. And so earlier I talked about at LDH, we developed health equity action teams. I think that one thing that you guys can do as helpers inside the behavioral health system is develop a team to execute on an ongoing basis the development of a behavioral health disparities impact statement or some sort of pseudo impact statement. Again, you know what those vulnerable populations are. You need to have some sort of statement in place that helps push you to constantly assess and move things forward so that you can deal with those disparities. Develop protocols and processes and programming and services informed by the client's social determinants of behavioral health. 3, identify the critical components of successful integrated healthcare models for vulnerable populations. Earlier, I stated that integrated healthcare is not the only intervention that one can use to help reduce health disparities. There are many things out there, and we need to continue to identify what those best practices are in relationship to meet the needs of particularly vulnerable populations, people who are not speaking English. And then 4, focus on leveraging cultural protective factors, provider language fluency, and trained workforce. And I think that if one is centering their work to reduce behavioral health disparities and improve equity in these areas, developing a team where you're looking at data on an ongoing basis and you're reporting that information back to leadership, developing protocols and processes and programmings that are looking at social determinants of health, developing, identifying the critical components of successful integrated healthcare models for vulnerable populations, and not just come to the table and say, oh, the only thing that we need to do is integrated healthcare and that's going to be it. No, more can be done. We need to be looking at what those best practices are and focusing on leveraging cultural protective factors and provider language fluency and trained workforce. These are things that need to be ongoing and need to be happening on a consistent level, at a consistent level inside health organizations. We are not all having the same experiences. We do not all come from the same environment. And so as helpers, we need to be taking that into consideration when we're developing programming. And when you start to do this, when you start to understand that there are social constructs, there are policies, there are organizational and interpersonal factors that come into play in that affect people's ability to be well and healthy. When you start to incorporate all of these things into your work, I think we'll start to see improvements as it relates to health equity and reductions in health disparities. So I leave you with, this is about intentionality, and this is about understanding that we're not all having the same experiences. Thank you so much. I am Dr. Earl Benjamin. I'll see you at 6. No, just kidding. Thank you guys for having me. Okay, cool.
So one for our question, first question we have is, Vivian Davis says, thank you for outlining the DrHSc plan. Are there some examples of communities that have been implementing these practices? And can you share specific activities?
Yes. So as a result of COVID-19, something that needed to happen, and this was something that we developed the plan, our health equity plan, before COVID-19 came on the scene. And inside our plan, we were in the process of identifying community educators who were volunteers, who self-identified, and using them to provide training to them, resources to them to share inside community. And so when COVID-19 happened, we were kind of caught off guard. And we were sharing a tremendous amount of information on the news nightly. But information still was not trickling down the way we wanted to trickle down. And so one of the, if you study Dr. Michael Mechanic's universal and targeted interventions, you find that you must, in order to reduce disparities and improve health equity, you have to build communities' capacity individually and the community-wide capacity to deal with the disparities that are happening. And so what we did inside LDH, inside my office, we created LDH Health Promotion Ambassadors. And these individuals are self-identified health educators. They grandmas to doctors or providers in the community who we provide education to them every 2 weeks about the ins and outs of COVID-19. We've had sessions around mental health, behavioral health. We've had sessions around seniors and COVID-19. We've had sessions around COVID-19 and food sustainability. And so we are building their capacity to understand the full dynamics of COVID-19, and we're hoping that they are sharing this information within their respective communities. And so for me, as a helper, as a person who understands that it's not enough for me just to go and say, this is what you need to do. I have to build your capacity. That is one of the areas that I think that as a helper, that we all can do better in. It's just leaning into community and not always thinking that, oh, I have to do this by myself. I have to do all these activities by myself. There are assets inside communities, and there are people and organizations that work inside communities, and we need to do a better job of leaning into them.
Next question.
Are there model states that you recommend for people to go and get some more information about health equity plans in other areas?
Yes. Yes. So you can look at our health equity plan. It's probably one of the most detailed ones because it tells each office what to do specifically. You can look at Minnesota. Minnesota has a health equity plan, and California. I think Minnesota and California's health equity plans, when we were doing our homework, they were probably the most robust, a bit abstract at times, but they were the most robust. But I will say this regarding LDH's health equity plan. It's the first health equity plan in the South, in the southern state. And it's also the first health equity plan of its kind in this nation, in that it tells each office what to do specifically. At its core, what we're trying to do, we're just trying to place health equity at the center of everything that is done. Typically, when you think about disparities, you think about it at the end. Okay, here goes the program. Oh, yeah, we need to do some disparity stuff. And so what we're trying to do is change culture to where when discussions get had about a program, at the beginning of that program, we have discussions about health equity. We already know that women don't have the same outcomes when it comes to men. We know that at the beginning when it comes to behavioral health issues. We know that LGBT youth don't have the same outcomes. We know that at the beginning. We know that people who live in rural parts of the state, they don't have the same health outcomes. We know all of this at the beginning. So that information should be used at the beginning and not at the end.
Another question that we've gotten, can you provide information on how to join the network receiving information? I'm guessing, this is from Wendy Bowen, I'm guessing she may be talking about when you were speaking earlier about going out and actually talking with other people and spreading information.
Okay, so our LDH health promotion ambassadors, those are our LDH, I think you're talking about our LDH health promotion ambassadors. If you could give her my email and we will follow up with her with that information. And again, LDH health promotion ambassadors are self-identified individuals that we provide training to on a bi-weekly basis. And building right now, we're only focused on COVID-19 and anything related to that. And so we're building their capacity to understand COVID-19 information, but also to share COVID-19 information. And so we're in the process of also getting a bit more resources so that we can identify some of our ambassadors to give them a stipend so that they can do this on an ongoing basis, and so that we can get information from them about how they're sharing this information. We cannot, as LDH, we cannot, as helpers inside the organization, inside this state, do this work alone. We have to lean into community.
There are no other questions in the chat right now, or in the question and answer box. But I'd like to ask you, would you please highlight your website once more?
Okay. So if you go to Google, or if you go to any search engine and you put in LDH, Office of Community Partnerships and Health Equity, our webpage will pop up. And on our webpage will be information about the LDH Health Promotion, LDH Health Promotion Ambassadors, will be information regarding our Health Equity Plan, will be information regarding the Health Promotion Ambassadors Toolkit. The toolkit is on our webpage. It will also have staff information about my staff, information about myself, and information about what it is that we're doing to help operationalize health equity practices and protocols in LDH. And again, I just want to stress that we are not all having the same experiences, and we all know this. And so we have to respond accordingly. Cookie cutter is not going to get it.
Well, we don't have any more questions. That's something like this.
All right.
We do want to thank you so much for your time. Apparently there was some technical difficulty, and so some of the questions weren't heard. But I want to remind everyone that this has been recorded, and so they'll be able to go back and review it. And we're sorry for all of this.
Thank you, guys.